Hello friends, we have learned about the anatomy of the external layer, the various disorders associated with the external layer. Now we will be starting with the mid layer, and to start with, it is the anatomy of mid layer cleft that we will be dealing with first. Okay, now first of all, what do you mean by mid layer cleft? Mid layer cleft is not just mid layer alone. Okay, mid layer cleft means the eustachian tube, mid layer, the adductus, the mastoid antrum as well as rest of the mastoid air cell system. So this whole thing is what is meant by the mid layer cleft. Okay, now before going into the anatomy in detail, we have to know how this mid layer cleft is developing, isn't it? Now we have learned that the first ectodermal cleft is what forms the external canal. What have we learned? This ectodermal cleft debends to form the primitive EAC initially, and this primitive EAC forms a fibrocartilaginous part, and later there is epithelial proliferation to form a solid meatal plug, and that later recanalizes to form the whole of the external canal, which consists of the cartilaginous EAC as well as the bony EAC. And this first ectodermal cleft is actually growing towards the tubotumanic recess that you saw here, which is formed from the first and second pharyngeal pouch, and these pouches are joined together to form the tubotumanic recess, and the tubotumanic recess forms the eustachian tube, the middle ear as well as the mastoid antrum. Okay, now the rest of the mastoid air cell system is developing along with the development of the tubotumanic recess. Okay, this tubotumanic recess actually goes on to form various spaces. What are these spaces? In the middle layer you have got various spaces such as mesotympanum, epitympanum, hypotympanum, right? All this you will be learning soon, but for now during the development you have to know that these spaces within the middle layer along with the pneumatization seen within the temporal bone, that is a mastoid air cell system. This mastoid is actually developing from the temporal bone, right? The temporal bone, there are two parts from where the mastoid air cell system are seen. They are the petrous temporal bone as well as the squamous temporal bone, and in these temporal bone the tubotumanic recess undergo pneumatization, and here when it pneumatizes it forms the mastoid air cell system. Okay, so as you can see in this picture, there are some sacs or sacs being formed. Okay, this is the tubotumanic recess area, and this recess is forming various sacs, and it is from these four sacs, that is the sacus andicus, sacus medius, sacus posticus, okay, sacus superioris. Okay, it is from these sacs the various structures in the mid layer develop. Okay, and not just mid layer, the various spaces within the mid layer as well as the temporal bone pneumatizations occur from these spaces. Now what are the parts of the temporal bone? I told you in the temporal bone the petrous and the squamous part contributes to formation of the mastoid air cell system, right? And so the posterior saccule of this sacus medius along with the sacus superioris forms the total of the mastoid air cell system, and this posterior saccule contributes to formation of the petrous temporal bone. This sacus superioris forms the squamous part of temporal bone. Okay, so the pneumatization within the petrous part of temporal bone is developing from the posterior saccule of the sacus medius, and within the sacus superioris is forming the squamous part of the temporal bone's pneumatization. Okay, now what happens when these join together? There will be a partition between them, right? And this partition later breaks down during development. Now if it fails to break down, as you can see here, that is the partition between the pars petrosa or the posterior saccule of the sacus medius and the sacus superioris. If it fails to break down, what happens? There will be persistence of the conus septum Okay, persistence of that partition is what is known as the conus septum. Okay, now what happens if it persists when you are doing a drilling to remove the disease from the mastoid antrum? Mastoid antrum is of course the largest mastoid cell, and it is seen deep within the petrous cells. Okay, now if you are going deep and if you encounter this conus septum, you will think that you already reached the mastoid antrum, right? You are going into the posterior cranial fossa if you are going further, so you will be stopping drilling, and because of that there will be inadequate clearance from the mastoid. So that is the significance of knowing whether there is this conus septum or not. Okay, now when the development occurs, as you can see here, this is the ectodermal cleft and this is the endodermal pouch, right? In between them you have the mesenchyme proliferating here. Okay, so in between them develops the tympanic membrane, where the first ectodermal cleft is meeting with the first pouch with mesoderm in between. Okay, so here as you can see here, there will be ectoderm here and mesoderm will be in the middle, and inner there will be endoderm. Okay, so what is the structure which forms a partition between the external aortic canal and the mid layer? It is the tympanic membrane, and yes, the tympanic membrane consists of all three germ layers. That is, the epithelial layer develops from the ectodermal cleft, the middle fibrous layer from the mesoderm, and inner mucous layer or the mucosal layer is from the endoderm. Okay, so these are the parts of the tympanic membrane. Okay, so this is how the mid-layer cleft develops, and yes, mid-layer cleft has got a conus septum which later undergoes regression, and if this conus septum persists, it can lead to a inadequate clearance because the conus septum will mistaken the surgeon for the mastoid antrum. Okay, so he won't go deeper and remove the disease from the mastoid antrum. Okay, so that's about the anatomy of the mid-layer cleft. Now coming to a little bit of the histology of the mid-layer cleft. What is the layering of what is the layer of the mid-layer cleft? How is it being layered? For example, we know that the pseudostratified ciliated columnar epithelium is all over the trachea, the lungs, right? It is forming the respiratory epithelium. And what is forming the what is the epithelium which is seen covering the mid-layer cleft? This same pseudostratified ciliated columnar respiratory epithelium is covering the most of the mid-layer cleft. Okay, most of the mid-layer cleft is being covered by it. And yes, why is it known as pseudostratified? Because as you can see in this picture, they are in the same layer, but it appears like they are in different layers. So it is not stratified, but it appears to be stratified. So it is false stratification happening here, right? So it is called pseudostratified. And along with that, as you can see here, there are some goblet cells here, and this helps to secrete mucus. Okay, and because of that, when you have secretions coming from the mid-layer, it will be mucoid in nature. Okay, the secretions from the mid-layer will be mucoid in nature. Now, what is this? You can see cuboidal epithelium. Now, where is this cuboidal epithelium seen? Of course, it is seen in the nephron, the kidney, etc. But for now, where is it seen? In the thyroid also you have cuboidal epithelium, right? Okay, but cuboidal epithelium is also seen within the mid-layer. Where is it seen? It is seen covering the promontory, and because of the single layer of cuboidal epithelium over the promontory, it will appear ivory white. Okay, this promontory, because of the single layer. And yes, when there is a congestion in that area, it can be easily seen. For example, the Schwartz sign in active otosclerosis is seen easily because of that cuboidal epithelium. Okay, so That's about the respiratory epithelium and the cuboidal epithelium. And of course there is the pavement epithelium. And where is this pavement epithelium seen? What is this pavement epithelium? It is a single layer of squamous epithelium. Okay. Now where do you see this single layer of squamous epithelium? It is seen in the area of the mastoid, antrum, additus, attic. Okay, all those areas being lined by the single layer of pavement epithelium. Now, the pavement epithelium does not contain any goblet cells. So this is the reason why in the case of attico-antral disease you have scanty, foul-smelling, purulent discharge, but in the case of mucosal disease you have profuse mucoid discharge. Okay. Now coming to the anatomy of medullary cleft in detail. First of all, let's learn about the anatomy of eustachian tube. Now what is this eustachian tube? Eustachian tube or pharyngotympanic tube connects the middle with the nasopharynx, and as you can see here, it is coming from the anterior end of the middle and goes into the nasopharynx about 1.25 centimeter behind the posterior end of the inferior turbinate. Okay, now while learning the anatomy of the eustachian tube, you have to learn certain dimensions, and you will be surprised to know that the dimensions are kind of similar with that of the external aortic canal. Just like the external aortic canal, this eustachian tube is also having a cartilaginous as well as bony part. Okay, in external aortic canal, what did we say? The cartilaginous part is 8 mm and the bony part is 16 mm, whereas here the cartilaginous part is the one which is more lengthier, in contrast to external aortic canal where the bony part was lengthier. So here the cartilaginous part is 24 mm in length and it is seen medially. That is also a contrast with the external aortic canal where the cartilage is seen laterally, and it is having 12 mm bony part laterally. Okay, and yes, this junction between the bony part and the cartilaginous part is the narrowest part, and hence it is known as the isthmus. Okay, isthmus is the narrowest part, right? Whereas in the case of external aortic canal, even though there is a bony cartilaginous junction which is narrow, it is not the narrowest area. The narrowest area is seen 5 to 6 mm lateral to the remaining membrane, and that is what is called the isthmus. Okay, and so this is the eustachian tube, and it makes an angulation of 45 degree with the horizontal. It makes an angulation of 45 degree with the horizontal, and this eustachian tube, its main function of the eustachian tube is to ventilate the middle. Okay, so most of the time it remains closed and it is open only during certain conditions. We will be going to that soon, but before that I will like to detail the anatomy of the eustachian tube. I told you that it has got a bony and bony part as well as a cartilaginous part, and it is similar to that of a flask. As you see here, it has got a dilated part and a not that much dilated area, and this cartilaginous part is seen embedded between the sphenoid greater wing and petrous temporal bone. Okay, between the petrous temporal bone and a sphenoid greater wing you have the cartilaginous portion. Okay, whereas the bony part is formed by the petrous and squamous part of the temporal bone. So between the sphenoid greater wing and petrous part of temporal bone you have the cartilaginous portion, and this cartilaginous portion is the one which has got some property to get closed. Okay, the other part is not compliant like the cartilaginous part because it is bony. Okay, so this cartilaginous part is opening into the area of nasopharynx, and it has got a medial lamellae and a lateral lamellae like this. As you can see here, the medial lamellae is the part which is medial and it is more, whereas the lateral lamellae is smaller and seen laterally, and from the lateral lamella extends the tensor veli palatini, and underneath the medial lamella you have the levator veli palatini, and you have the Osman's pad nearer to the tensor veli palatini. Okay, now lateral and posterior to the eustachian tube orifice you have the fossa of Rosenmuller. Okay, fossa of Rosenmuller, and so this eustachian tube is connecting the nasopharynx with the mid-layer, and its main function, as I already told you, is ventilation. As you can see here, ventilation is the main function, but apart from ventilation there are certain functions such as protection. How does it protect? It protects the mid-layer from the nasopharyngeal secretions, regurgitating it. How? By keeping it closed. Here, because of the isthmus, there is a narrowing and there is a formation of valve-like area in the area of the cartilaginous eustachian tube because of the closure of the cartilaginous portion. And how does this closure happen? This closure is actually happening spontaneously because of the elastic recoil. For opening, you need the tensor veli palatini and levator veli palatini to function together, and tensor veli palatini is the main opener of the eustachian tube. Okay, most of the time it remains closed, and this closure keeps the mid-layer protected from the secretions. Okay, and of course drainage is another function. Okay, drainage, but the major function is of course ventilation. Ventilation is the most important function of eustachian tube, but protection and drainage are also function. Drainage from the mid-layer to the eustachian tube can occur when it gets open. Now, how does the eustachian tube get open? When you are yawning, as you can see here, or when you are eating, and when you are coughing or sneezing. All these activities can result in opening of the eustachian tube. That's why while going in a flight, to prevent the eustachian tube from getting locked, okay, you always ask the patient to chew something, okay, so as to open the eustachian tube. We will be learning about locking of eustachian tube and the disorders associated with that in my coming sessions. For now, just know this. Okay, now if you look at this picture carefully, you can see how tensor veli palatini is helping to open the eustachian tube, the cartilaginous portion of eustachian tube, by pulling on the lateral lamellae. This is the lateral lamellae that you see here, and this is the medial lamellae, right? So that is being opened because of the pull of the tensor veli palatini muscle. Now, what are the differences between an adult eustachian tube and a kid's eustachian tube or an infant's eustachian tube? In an infant's eustachian tube, it is usually shorter and wider, and is more horizontal, as you can see here. This is the infant's eustachian tube, and the angulation is only 10 degree, in contrast to adults where it is 45 degree angulation, 36 millimeter in length. Here it is only 18 millimeter in length, or it is approximately half of the length of the adult eustachian tube, and it is wider as well. And because of that, there is high risk of the nasopharyngeal secretions going into the mid-layer and the child getting a mid-layer infection, especially while being fed in the supine position. Okay, so you always have to tell mothers not to breastfeed in a supine position because of the high chance of mid-layer infection. Okay, now coming to one of the questions that has been asked in the exams. Which of the following attains adult size at birth? Okay, ear ossicles, extenotic canal, mastoid, parietal bones. This is a tricky question. Why? Because in this question it is said mastoid. Okay, mastoid includes mastoid antrum as well as mastoid air cells. Mastoid antrum actually attains adult size at birth itself, whereas the mastoid air cells is, rest of the mastoid air cells are undergoing development even after birth. The pneumatization is continuing to take place, and yes, the tip cells, they will develop later. The mastoid tip is getting developed because of the pull of the sternocleidomastoid, and this develops later on. And so mastoid won't be having adult size at birth. Okay, whereas the extenotic canal it has got two parts, a bony part and a cartilaginous part. I told you the cartilaginous part is developing first and it will be developed at the time of birth itself, whereas the bony part is developing later on, right? So that is not the answer. Now how does the urosicles develop? The malleus and ingus develops from the first pharyngeal arch and the stapes suprastructure from the second pharyngeal arch. Now the footplate of stapes is developing from the otic capsule, and this same otic capsule is leading to the development of bony labyrinth, and it is on this bony labyrinth that you have the oval window which is getting covered by the otic capsule, and these urosicles are well developed at the time of birth itself. So the answer to this question is A, urosicles. Now coming to the next question, most common congenital middle abnormality. It is of course fixation of footplate of stapes. Why? Because when the fixation of footplate of stapes occur, it is happening during the time of development, because the otic capsule which forms a footplate of stapes is being formed by the same thing, the otic capsule that forms the bony labyrinth, and so they develop together and can result in fixation of footplate of stapes, which is the most common congenital middle abnormality seen. Okay, now that you learned about the anatomy of eustachian tube, before going to the anatomy of middle ear, you will be learning about the anatomy of the mastoid air cell system. Now this mastoid air cell system resembles a honeycomb, doesn't it? And this mastoid air cell system can be cellular, diploic or sclerotic. When the pneumatization is well developed, it can result in a cellular mastoid. When the pneumatization is not at all occurring, or the pneumatization failed to develop due to some causes such as infection, it can result in a sclerotic mastoid, or as you can see here, an acellular mastoid. So there will be no cells, it will be completely opaque, as you can see here. When it is partially opaque and partially cellular, it is called the diploic mastoid. Okay, diploic mastoid. Now these are the various cell tracts seen in the area of the mastoid air cell system. You can see mastoid antrum, which is the largest mastoid air cell. Around the antrum you have the periantral cells, and then you have the tegmental cells near to the tegmen, right? And apex, near to the apex you have the medial apical and lateral apical. Then nearer to the sigmoid sinus you have the lateral perisinus and the medial perisinus. Okay, but the most important cells that you have to remember are the retrofacial cells, which are seen around the facial nerve, because while drilling, when you are trying to remove that, there is high chance of injury to the facial nerve, right? Then you have the tip cells in the area of mastoid tip, then peritubal cells around the eustachian tube, petrous apex cells. Then there are some accessory mastoid air cells such as zygomatic cells, squamosal cells. Okay, and even in the area of synodural angle also there are some cells, and of course you have the periantral and perisinus cells. Okay, so I told you temporal bone contains the external canal. It is seen as a tunnel within the temporal bone, and this temporal bone has got the squamous part, the petrous part, the styloid part, and a tympanic part. Okay, and this tympanic part is the one which forms the floor, anterior wall and the posterior wall of the tympanic ring. Okay, tympanic ring, and it is into this tympanic ring the tympanic annulus of the tympanic membrane is getting attached. Okay, tympanic ring, the tympanic annulus is getting attached, and so this is the mastoid, and this mastoid has got a petrous part and a squamous part, and they join at the area of petrosquamous suture line, and when they persist, it results in corner septum, and when there is corner septum, it can result in incomplete clearance of mastoid disease, right? So this is the anatomy of the mastoid, and here the mastoid air cell systems develop. Okay, and where is this mastoid seen? The mastoid has got a squamous part and a petrous part, right? The mastoid is seen within the petrous and the squamous part of the temporal bone. This colored area is the squamous part and this colored area is the petrous part. Okay, and here you can see inner ear seen within the anterior slant of the petrous temporal bone, and on the posterior slant you have the internal rotary canal. Now what do you see here? This is a picture which depicts the area of the mastoid antrum. Okay, how will you reach the mastoid antrum? To reach the mastoid antrum, you have to go through the suprameatal triangle. Okay, suprameatal triangle. Now, before going to the suprameatal triangle, what is this triangle of attack? Triangle of attack is the area where you can safely drill while doing a mastoid surgery, and it is bounded by the tegment plate superiorly, sigmoid plate posteriorly. Inferiorly you have the, here we have the synodural angle or the Sittelis angle. Okay, this is the Sittelis angle. Sittelis angle is another name for synodural angle. Okay, inferiorly you have the mastoid process and the digastric ridge. Okay, anteriorly you have the posterior superior wall of the external rotary canal. Okay, so this is the safe area, and on the floor you have the lateral semicircular canal. So this is the safe area for drilling. While drilling, you have to access the mastoid antrum first, right? For reaching the mastoid antrum, you have to go through the McEwen's triangle or the suprameatal triangle, and this McEwen's triangle is bounded by anteriorly you have the posterior superior wall of the external auditory canal. Okay, anteriorly you have the posterior superior wall of the external auditory canal. Then superiorly you have this temporal line. This is the temporal line, and posteriorly you have the tangent drawn to the posterior superior external auditory canal, going to bisect the temporal line. Okay, so all these forms the suprameatal triangle or the McEwen's triangle. If you drill through the McEwen's triangle, you can reach the mastoid antrum, and you have to make the adductus patent. Sometimes some granulation tissue or some discharge or something may be blocking the adductus. If the adductus is blocked, the ventilation from the mastoid air cell buffer system is getting reduced, and that can resulting in increased tendency for middle ear infections. So it is very important to do that. Now, so this is what I told you. This is the area where you drill. Superiorly tegmentary, posteriorly you have the sinus plate. This is the synodural angle or the Sittelis angle, and here you have the lateral semicircular canal in the floor. So floor is being formed by the lateral semicircular canal, and it is the area where you form the middlemost boundary of the McEwen's triangle. Okay, or middlemost boundary of dissection, not McEwen's triangle, middlemost boundary of the triangle of attack while you are drilling for a mastoidectomy. Okay, so you have learned about some new things. What are they? We learned about Sittelis angle is called the synodural angle. We learned about McEwen's triangle, which is the same as suprameatal triangle. Why is it called suprameatal triangle? Suprameatal triangle because it is above the meatus, right? If you have the external auditory meatus here, if you have the tangent here, this is the tangent to the lateral semicircular canal, and if this is the temporal line going like this is the area of the supramedullary triangle. This is the area where you will find the mastoid antrum. We have already learned that mastoid antrum can be seen overlying the cymba conga, right? When you press off the cymba conga, if there is tenderness, it means it is due to the involvement of mastoid antrum, right? So both McEwen's triangle as well as cymba congae indicate towards the involvement of mastoid antrum. Okay, so that's about the anatomy of midlear cleft. And then what else you have to know? There is a lateral semicircular canal seen in the floor, I told you, when you are drilling, right? And this lateral semicircular canal is seen projecting into the medial wall of the midlear. That also you will be learning soon. And this lateral semicircular canal, when drawn posteriorly, when extended posteriorly like this, when this lateral semicircular canal, this is the lateral semicircular canal you see here, if a line is drawn posteriorly like this, going to bisect the posterior semicircular canal, that line is what is known as a Donaldson's line. Okay, that is called the Donaldson's line. And just inferior to the Donaldson's line, you have the endolymphatic sac. Okay, endolymphatic sac. So this endolymphatic sac is formed by the continuation of the utricular-saccular duct, which is formed from the utricle and the saccule, and it goes downwards and seen just below and inferior to the posterior semicircular canal. Now to access the posterior semicircular canal and the area below it, you have to draw a line through the lateral semicircular canal, bisecting the posterior semicircular canal. So just below and inferior to that you have the endolymphatic sac. Okay. Now because of the endolymphatic sac being present there is high risk of injury to endolymphatic sac when you go through the midlear to approach the posterior cranial fossa. Okay, posterior cranial fossa, when is being approached through the mastoid area, there is high chance of injury. So to prevent that, you always have to go above this Donaldson's line. Okay, and through which triangle you go to reach the posterior cranial fossa? It is through the Trotman's triangle, and this Trotman's triangle is bounded by sigmoid sinus posteriorly, then you have the superior petrosal sinus superiorly, and of course you have the labyrinth anteriorly. Anteriorly you have the labyrinth. Now the angle between the lateral semicircular canal, posterior semicircular canal and the superior semicircular canal is what is called the solid angle. Solid angle. Okay. Now how do you identify if it is the lateral semicircular canal or posterior semicircular canal? The canal which is nearer to the mastoid will be the lateral semicircular canal, right? That is, if you have the medial wall of the mastoid here, it will be like this lateral semicircular canal. Okay, and it will be the one which is projecting into the medial wall of the midlear, and the posterior semicircular canal will be kind of like this, and the anterior semicircular canal will be like this. Okay, and the angulation between these three canals is what is known as the solid angle. Okay.